talk about transcutation. All right, number 3. Beta endorphin release, produced primarily in the anterior pituitary, okay, again in the brain, stimulate AD or A delta and C pain fibers via twitch muscle contraction. Parameters are low rate, 1 to 5 pulses per second, moderately long, not like it was before. And this is what we did. Did we do this? I think we got to this yet. Moderately long, which is a pulse width of 200 microseconds. It is very important that you know the difference between those two M's. What micro is and what milli is. So make sure when you see those two M's, you know the difference. The intensity would be motor, and that's long-term relief. So these are just various ways that relief can occur. Next page. So, what happens? The pain cycle gets, or we have an altered pain cycle. Injury happens, you bump your toe. You get pain. Now you have muscle guarding and some spasm. It leads down to inflammation, so we get that swelling. And then you have decreased circulation that's in the area that leads to increased metabolite accumulation. You have all of this going on in that body part, so now it's not moving that much, so we get dysfunction. And of course, if there's dysfunction, then there's impaired motion, because when you stop moving it because it causes pain, then over time you can get stiff, tight, maybe even lead to contracture if you don't do something about it. Okay. Internally, inside the body, what is happening inside the body? Internal, microscopic, very hard to see changes to the increase to pain. Decreased circulation. All right, so the blood is not moving. Okay. Decreased oxygen. Why? Because the blood carries oxygen, so it's not moving. Decreased lymphatic clearing. Why? Because there's nothing just moving around, because everything is just stagnant. Okay. Increased metabolism, because we have all of this chemical reaction just sitting in the blood and it's not traveling anywhere. The car broke down. We can get that car moving again, we can get things rolling. But the car broke down, so all the luggage is in the car, everything is there. Okay?
Why is it increased?
Because everything is sitting there in that blood. Because when you have an increase in pain, you have an increase of activity that happens in your body, because it's almost like you're stressed.
Okay.
Decrease nutrient supply. Of course, the blood is not carrying anything around. Increase concentration of metabolites. Everything is sitting still there. Increase muscle fatigue. Muscles are not strong because blood is not going through. Muscles are not moving. You don't have the function that you need. Increase inflammation and edema. Basically all the same.
Why the metabolism is increased?
Because when you have increased pain, you're very agitated. As opposed to if you didn't have a lot of pain, and you wouldn't have a lot of chemical movement in your body. But when you have a lot of pain, it's, even though you're not moving per se, it's almost like when you're stressed out from a...
It's like adrenaline thing.
Yeah. There you go. There you go. Good. All right, so positioning of electrodes. So what does this mean? Where are we supposed to put these things? That's what that means. May use a combination of these if you want to. So, letter A says the site of pain. Okay, so where can we put electrode? Right on top. It hurt right here, put it right there. That's where we can put it. All right. Number 2, nerve roots adjacent to the spinal column, segmentally related to the involved dermatome. Turn to page 81. Anybody ever seen a dermatome chart or a myotone chart before? I know you said you better say one. All right, so dermatomes or myotones, which myo refers to muscle, all refer to segments, as it says here in the body, segmental innervation by the skin, the cutaneous area supplied by a single nerve. So if we're dealing with, let's say, the C5 nerve, then the nerve comes out of the neck, and all of the area that's associated with C5 is where that sensation comes from. So if I touch this area here, then I am touching an area that's associated with C5, or cervical 5, all right? You'll get a lot of this when we get to spinal cord, because this is why patients can or cannot move based upon where the innervation is from the spinal cord down to the body part. If we have a C5 quad, then that C5 quad is able to move their biceps. So we think, you know, if it's a quadriplegic, then here, and it's completely done, and the person can't move. But that's not 100% true until we get much higher in the spinal cord. So if I'm going C5 quad, then that nerve runs all the way down, and it actually innervates the biceps. So I can do movement with my biceps, but I'm a C5 quad. So I lost C6, which is extensor carpi radialis. So I can't do that, but I can do this. Okay? So depending on what's innervated, that'll talk about what you can and can't move. In this case, depending on what's innervated, it will talk about what can and cannot be felt. All right? So you may have to put pads along a dermatome innervation. So if I'm dealing with pain that's associated with, for example, C5, then I may put it over that nerve root that comes out of the spinal cord to associate everything that's innervated by C5 on the skin. Okay? Okay, where are we? Way back.
Do we have to learn this chart?
No.
Oh.
Not yet.
Yet? So we will.
When we get to spinal cord, yes, we'll talk about it again. Okay. Okay. Along the course of a peripheral nerve. All right. So along the course of a peripheral nerve. Let's see here.
Where are you?
Letter C, page 3. Yeah, along the course of a peripheral nerve. So if a nerve runs all the way down here, then I can set up electrodes along the course of that nerve and treat that body part, okay, or treat that area or injury. Related to motor trigger acupressure points. Motor or trigger acupressure points. Let's go.
It's acupuncture. Is there?
Say that again.
It says acupuncture. Is there a difference? I mean, I know that there's a difference, but like in the book. You said acupressure.
I'm sorry. Okay, acupuncture is when there's a needle that's puncturing the area. Acupressure is.
That's what this says.
Yeah.
Is it puncture? What is it?
Okay, acupuncture points, acupressure points, all the same.
Okay.
Yeah, it's just how you stimulate it. How you stimulate it. So, acupuncture or acupressure points. Let's go to page 73. We talked about this a little bit in the fall, and we're going to look at it a little bit deeper now. And we'll treat for one of these, we'll treat for this in lab soon. All right, we're reading down, and this person, we talked about this in the fall, the person has reflex sympathetic dystrophy. And we want to get rid of this pain in the arm. So we're going to use this acupuncture point, and we can stimulate it with electricity. All right. If we look in the objective section, I'll read the second line down at the end, and it says moist heat with E-stem times 30 minutes as follows: 1-inch electrode at the Hoku point of LI4, or large intestines 4, and that's again acupuncture point, which is the dorsal web space of the hand, and then the ulnar aspect of the same hand. So where is that? That is here. So the Hoku point is here. And then, of course, we'll put another electrode, because we need one there, right there. And then we'll treat this acupuncture point. All right? Now, it is said that if you press this Hoku point right here, because that's Japanese, all right? Hoku point right here, then I can help to relieve, acupressure-wise, a headache. You heard that before.
What again? Where?
Oh, now you're listening. This is a good place or a good acupressure point to relieve a headache or sinus problems or allergies. All right, so pressing here and holding. It's a good acupressure point to relieve a headache or a sinus condition or an allergy.
Yeah, I'm trying to do it.
You pressing right now? We'll get more into that in book 3 when we get into acupressure. Okay, points of lowest electrical resistance. Now, when E-stem is going through the body, if it doesn't have a lot of secretaries in the way, it'll be a little easier to go through. But what might be some issues for E-stem going through? Dirt, so dirt on the skin, oil on the skin, that can be some resistance. Dead skin, these can be some resistant things that can cause, so you might have to clean the skin if you see that there's some grayness. Some grayness, you know. Now, lowest electrical resistance goes through great blood. Blood blood, it travels wonderful through blood, but it doesn't travel that great through bone. Now, we treated in lab, I think it was DX number 9, and they said, you want to put this right over the malleolus because we have a ankle sprain. Yes, we want to put it over the malleolus because guess what? With an ankle sprain, you really can't feel the malleolus. Why not? Because there's a lot of swelling that's right there. So you're fine. Now, once it goes down, then you may want to go up or go down. But when there's a lot of swelling at the ankle, there's a lot of swelling over top of the malleolus, and that ankle is... So yes, you want to go right over top of where that area is swelling. Once we get down, then you don't want to go over top of that bone because that's a lot of resistance to the electricity. Then I want to get to a meaty area or muscular area. But as long as there's that swelling there, water, blood, lymphatics, that carries good. And that's a good conductor of electricity. All right, so we want to put it right there. All right, let's see here. Advantages, meaning advantages of using the stem. Valid method of controlling pain regardless of the etiology. What is that? Cause, okay. Duration, age, sex, or psychological factor. Biologically safe, superior to neurosurgical destructive procedures or drugs. Non-invasive to the skin. Portable, effective and easy to apply. Okay. Indications, meaning 410s. Acute pain, so we got some simple strains and sprains, good for that. Good for sports-related injuries. Usually sports-related injuries are knee injuries and ankle injuries. ACLs, ankle sprains, things like that. Trapezius strains, rib contusions, tendonitis, epicondylitis, post-surgical pain. So after surgery, meniscectomy, laminectomy, appendectomy. Now, that is a removal of the appendix, right? And the appendix is a little piece that's right there at the bottom of the large intestines. And the reason why they're taking it out is because there's a lot of infection that could be hazardous to your life, is life-threatening. All right, so they want to get it out. But of course, when this person has pain, we want to make sure that we help to relieve some of that pain. So it's a life-threatening infection, so they want to get that appendix out right away. Okay, then chronic pain. Low back pain, neck pain, headache. You do it for a headache, forehead or the back of the head. Okay.
Would you also treat Heaven's Gate. We call it Heaven's Gate in the old
Heaven's
country.
Gate. Oh, you going deep on me now.
Yeah, we got Heaven's
Yeah, we
Gate.
treat Heaven's Gate. Yeah.
But we would treat
Don't
that.
treat Hell's
with-
Flames. But, you know.
All right, forget it. But would you treat that with TENS
Yeah, you good.
for headache?
Yeah.
You'd put one here, where would you put the other one?
On the lateral, like the ulnar styloid head region, just up a little bit
You
on
know
some
what, you
meat.
just said that.
Yeah, same thing.
Okay.
All right, arthritis, and these are long-term painful issues that, you know, chronic is long-lasting type pain that just won't ever go away, it seems like. Arthritis and DJD. What is that, DJD? Phantom limb. Anybody remember that?
Yes.
That comes with what DX?
Amputees.
They cut it off, it feels like it's still there. All right. Herpes zoster. That's nothing more than shingles. Okay. It's a viral infection. And it really is a secondary to the reactivation of chickenpox. Tic-Doclerex. That is a painful spasm of the trigeminal nerve. Painful spasm of the trigeminal nerve. Now you know what the trigeminal is, don't you? Trigeminal referring to what? Face. Okay. So that's really that. It feels like a stabbing electrical shock. It's like a stabbing electrical shock in the face. Now, let's look at this here. Because we're gonna, and I want you to highlight this.
This is trigeminal one?
Say it again.
The end of the
End of the nerve. All right. So let's look at B7, cancer. Now, why is it that you think we could give E-stem for cancer?
Are they pain?
Because first of all, what do you think that E-stem could do if a person has a cancerous problem and you give them E-stem? Spread it. Now, good. And ain't gonna stop doing it. So why do you think the doctor would say, go ahead and give this person who has cancer E-stem? It's terminal. So all we're trying to do is just give them some sort of peace before they just go about it. So we're looking at a terminal issue. Referred pain. Referred pain is pain away from the site of the injury. You know, a lot of times people say that they have, you know, I have all this pain in my leg. It just runs all the way down my leg. Oh, it's like, oh my God. But where is the pain coming from? Probably the back. Okay, so exactly the side. So it's probably coming from there. Contraindications. Pacemaker patients. Do not place on the thorax or torso, low back. May inhibit the device. So again, think a pacemaker is electrical. I mean, run by battery, but it's electrical. All right. So if you're sending in electricity in this body, you could cause the calibrations to throw off. Okay. And it says other implanted stem. Hold off on that. We're going to come back to other implanted stem. So not just the pacemaker, but there's some other things that can be implanted in the body too that we want to be mindful of. Over the carotid sinus. We don't want to do that too. Now, the carotid sinus is really just a pathway for cardiovascular control. So it is a blood pressure pathway. It really is a conduit between the heart and the brain. Okay. So if you put a E-stem pad on the top, then you can start changing the outcome of what blood pressure could be to the point where you can cause this person to pass out. Okay, so you don't want to do that. History of pregnancy. Why do you think not pregnancy? And of course we mean pelvic, low back region. not necessarily anywhere else, but stomach, trunk, low back, pelvic region. Why not there? We can cause a deformity, disability in that uterus and that fetus. We don't want to do that. Now, letter D, we want to make that a precaution, not a contraindication. History of cardiac disease. All right. Now, if this person has a cardiac problem, what do you think E-stim could do to the vital signs?
Change the vital.
It could change it. So, if we're going to treat this person, yes, we can treat them, but you might need to take the vitals before. You might need to take the vitals during,
After.
and you might need to take the vitals after. Okay, so we just want to be mindful. Not on the head, of face of recent CVA or TIA or someone with a seizure disorder. First of all, as far as a CVA is concerned, the brain normally tries to rebuild itself through alternate ways. So if the person had a stroke, the body is always going to try to repair itself. So there's been some studies that said that E-stim can help with that repairing. However, initially, if we look underneath, cognitive impairments if unable to apply safely and correctly. Meaning, if this person just had a stroke and you're doing E-stim, well, how are they going to tell you it's too much? Because so they're not going to be able to talk to you. Wait till they're able to talk to you.
That's a contraindication.
So, initially, right now, it's a precaution. Because you can see right there where it says precaution.
Okay.
Yeah, so it's a precaution. So you need to be, but on the recent, we want to be careful with those people. Because if they can't talk to us, then we don't know what's going on. If you have someone who has a seizure disorder, be real careful with them because they can pull the electrodes off. And if they pull off one, okay. Letter E, I think it's sitting off to the right there. Cancerous malignancy is a contraindication. Why? Because now we can cause it to spread, and they haven't been told they're going to die. Okay, so we don't want to take it any further. They're not terminal. Thrombus and thrombophlebitis. I think we understand that. The blood clot, you move the blood around, turns to an embolus, you cause problems after that.
So D is precautions, and E and F are still
You got
contraindications.
Yes.
The only one is D.
Only D is precautions.
Now, we talked about other implanted stem. All right. So, a Parkinson's patient may have a stimulation device implanted in them. Okay. So, whoever has Parkinson's for your PowerPoint presentation, you might want to research and find out where that is. Okay. But if they put this electrical device in the body, it can help to decrease the tremors. Because they have tremors. So if we put this device in the body, it can decrease some of the tremors. All right. Epilepsy. So they may have this patient who has seizures.
Where are you reading?
I told you, we writing this down.
Oh.
Let me go back.
Yeah.
Let me go back. I said I was going to talk about it. I'm talking about it right now. All right, so you have a Parkinson's patient. Write it down in the white spot at the bottom.
That's
There you go.
precaution.
You have a Parkinson's patient. And we're giving them we're not giving them, but they have been given an electrical implanted device in their body.
Oh.
All right? And this device has been planted inside their body to help decrease the tremors that they have, that shaking that they have. All right, that's person number one. All right. Person number two, they have epilepsy. Patients who have epilepsy have seizures. So we can put, they will put a electrical device inside their body to decrease or suppress some of the seizures in the body. And then the last one, Tourette syndrome. Anybody familiar with that, Tourette?
Yeah, it's ready. What's that?
It's a show. It was a movie out about this guy who he taught a class. I'm gonna have to find it.
Is he the teacher?
Yeah, he was a teacher. What-
Yeah, I don't remember.
He was like an elementary school teacher, and he found this this girl who actually married him or whatever. But every time he got with his students, he would that tremor would jump in. Well, for this type of patient, it would decrease the frequency of those what they call tics. All right.
That show and the one where they showed a lot of persons.
Say that again. Tourette's syndrome.
You said that it would help decrease.
Decrease the frequency. So how often? So if they do it like every 10 minutes, they might do it every 30 minutes.
No, I know what that is, but it was under.
The other implanted stem. So,
Okay, so if they get the thing, okay.
right, so anybody who has stem for a pacemaker, anybody who has, or some sort of device in their body for a pacemaker, and the other ones we just talked about, for the Parkinson's patient, for the epilepsy patient, for the Tourette syndrome patient, if they have any type
Can you
of,
spell the last one? I cannot.
I want you to look it up. Because if you don't know anything about it, I want you to know something about it. So look it up. See if I can get the phone.
Spelling?
No, it's recorded.
It's recorded? Yeah, I want you to look it up. All right, so,
All these are contraindications.
yeah.
If they didn't have the thing putting with Eastern Health, did any of it, or?
Yeah, it wouldn't help with that. It was just, we just go ahead and treat for whatever they have. But if they have a problem and we're treating, let's say, the upper tract, it might not work with them if they already have that device installed in their body.
Oh, okay.
Okay, I want to talk about some shock precautions. Meaning shock from E-stem. Just find a spot to write it. All right? So, to not shock your patient with E-stem. That's what we're talking about. Number one, you want to gradually increase the intensity. Gradually increase the intensity.
To not shock your patient.
Yeah, so you don't want to, hey! You want to gradually increase the intensity. So there's more than one way to shock a patient. That's one, if you turn up the intensity too fast. Okay. Number two, that we already know. Make sure that your electrodes are secure well. So very firm, secured electrodes. And then number three, don't increase the pulse rate and or the pulse width with the machine on. So let's say you turn up the intensity, they're feeling the tingling, and then you look at the pulse rate and it's like, oh, I need more than that. So you start pressing and turning up the pulse rate with the intensity already on. You can really shock the patient because you're changing the parameters, so you could be changing the feeling of what they're getting. All right? And that is it.
Goodbye.
Okay. A couple of announcements.
Oh my goodness. Something with the test.
Okay, I know you've probably been wondering why is it that we're not getting some stuff back. But when you first come in the spring, we are teaching 34 people. We're not teaching just 19. And they're taking a 5-credit class and a 2-credit class in 6 weeks. They was here 2 weeks before you. Okay. So to grade all of that, along with trying to do this too, gets to be a lot. So that's why you haven't been getting stuff back. You're going to get something back today. But that's why you haven't been getting stuff back, because teaching 34 people versus 19 people is very hard. So, I do have your ultrasound home assignment. Right here, I'm going to give that back. and I have an East End home assignment that you'll get that's here. I don't know when it's due, but it's in your thing. Okay. So we'll get to that in a second. Background check. There are still